All right. Our second speaker is Dr. Jack Burke. He's currently a professor of pharmacy practice and the Associate Dean for Postgraduate Education at the St. Louis College of Pharmacy. He earned his BS degree in pharmacy from the University of Missouri, Kansas City, and his Doctor of Pharmacy from the University of Texas. He completed his clinical pharmacy residency at Truman Medical Center in Kansas City, Missouri. Dr. Burke is a board-certified pharmacotherapy specialist and has been a clinical practitioner and faculty member for over 25 years. Please join me in welcoming Jack Burke as he talks about nephrology.
Thanks, Brian. It's a pleasure to be with all of you today. I'd especially like to welcome the people in the back of the room who I think are sitting on the California-Arizona state line. It's so far back. But anyway, I'm pleased to talk with you today. Sort of like Brian's presentation, we have quite a bit to cover. I don't have any conflicts of interest related to this topic. The learning objectives are on page 256 of the workbook, but this sort of outlines the topics that we will talk about. We'll talk a little bit about acute kidney injury. There is some sections in the workbook on drug-induced kidney disease, and we're primarily going to talk about contrast-associated nephropathy. We'll then talk a little bit about chronic kidney disease. Complications, particularly, we'll talk about anemia and mineral bone disease, and then we'll finish up with a case on drug dosing in kidney disease. Just to focus you a little bit, most of the content that relates to the pharmacotherapy exam will focus on patient-specific pharmacotherapy, which is domain 1, as you might expect, but I have one question in there that focuses on domain 2. So the first case, which is on page 261 of your workbook, is a 48-year-old man who came in with an acute myocardial infarction. He has a history of diabetes, hypertension, and smoking, and he's on a number of medications. When he came in, his baseline serum creatinine was 1 milligram per deciliter, but over the past 24 hours, his kidney function has declined, so his BUN is 20, and his serum creatinine is now 2.1, so it's more than doubled. His urine shows muddy cas, and he's been anuric for the last 6 hours. Currently, his blood pressure is 110 over 70, but he has significant peripheral and pulmonary edema. So our question is, what's the best assessment of this patient's kidney function? Okay. All right, so I see a few answers. I agree with those. And what I'm going to do, like Brian, we'll talk about the topic and then we'll come back to the question again. So acute kidney injury, this patient is obviously experiencing, is an acute decline in kidney function. That is often over a period of hours to days, but can even progress more slowly over a period of weeks, resulting in the accumulation of waste products. Often we see an increase in BUN, and often there's an increase in volume as well. The Acute Kidney Injury Network has 3 criteria that they use to classify somebody as having acute kidney injury. It can be as minimal as a 0.3 milligram per deciliter increase in serum creatinine, or an increase from baseline of more than 50%, or if you look at urine output, less than a half a mil per kilogram per hour for more than 6 hours. And we're going to look at the next slide, the rifle criteria that are sometimes used to stratify or classify acute kidney injury. So the 5 classification rifle standing for risk, those people who are at increased risk for acute kidney injury, those who have expressed some injury, those with failure, loss, or end-stage disease. So if we look at the GFR criteria, this particular patient would fall in the injury category because they have had more than a 2-fold increase in their serum creatinine from baseline. So it went from 1 to 2.1. If we also look at urine output, they are anuric, but they haven't had it long enough in order to meet the criteria for acute kidney failure. If it persists for another 6 hours, then we could reclassify the patient. But clearly the patient has acute kidney injury. estimating kidney function can be a little challenging in acute kidney injury. Most of the equations that we use on a regular basis really assume a stable serum creatinine. They're based on steady state formula calculations, and so that if the serum creatinine is rising, you would actually overestimate what the patient's GFR is based on that unstable serum creatinine. So those aren't very helpful. There's a few other equations like Brader and Jelliffe that may be a little bit more accurate but aren't well tested. If a patient is non-oliguric, unlike this one, then you can actually do a timed urine collection and actually measure creatinine clearance, and that may give you something a little bit better. In that case, you would just sort of average the serum creatinines over the urine collection time. So, anybody want to take another stab at the answer here after our discussion? Okay. So again, yes, because this patient is anuric,